there you are, who's going to talk about Active Minds and show a little bit of the video, and you're all welcome to join our club.
Yeah, so Active Minds is a national organization, and I'm the president of the chapter here at PLU. And basically, we discuss mental health, and the national organization is essentially just a broader group that discusses mental health as well. And so we're just very big on advocating how to talk about suicide and just how to overall just have a better conversation that's between peers about mental health, because that's a huge thing on college campuses. And we have a sign-up sheet over there, so if anyone's interested in joining the club.
You should talk in here so it gets recorded better.
If anyone is interested in joining the club, you're more than welcome to sign up over there. We would very much enjoy new members. And yeah, so we have a little video discussing what Active Minds is, a little bit more in depth. So we can go ahead and play that.
Getting on a college campus for the first time can be so overwhelming because you're kind of facing the world by yourself for the first time.
Growing up, I did have a lot of family members who suffered from mental health challenges. It wasn't something that was always talked about.
It's been very difficult to talk about what does it mean to be sad versus to be depressed? What does it mean to be stressed versus to be anxious?
After losing my friend, I needed something. I was struggling a lot myself.
I started Active Minds when I was a freshman in college after losing my brother, Brian, my only sibling, to suicide. Active Minds is a national nonprofit organization focused on changing the conversation about mental health. We're most well known for mobilizing young adults to get involved in and change culture around mental health.
We know that life is tough for young adults. And we also know that it's not just the students who have mental illness that have issues, it's all students. We have enough research to know that all students are dealing with things like depression and anxiety and the epidemic of loneliness.
Active Minds is serving as this institution on a campus that is getting students talking, having programming during Suicide Prevention Month, having stress relief activities during exams, screening movies, having panel discussions and keynote speakers, all with a mental health theme, so that it's not just that we're talking about mental health when there's a crisis, but we're talking about mental health every day.
One of the things I love about our partnership with Active Minds is that they are creative and engaging and relatable. It's just in this easy language, vernacular that you use on a normal. And I think that helps to decrease the stigma. It helps to start the conversation.
I love that Active Minds is able to make the topic of mental health very broad, so that way all people feel included in it.
We were thrilled to start working with the RAND Corporation to understand if Active Minds was really making a difference. It was a longitudinal study.
It has shown that the presence of an Active Minds chapter on a campus, just that alone, makes people access counseling more, feel more comfortable.
Those students had lower stigma and improved attitudes around mental health simply because they felt like their campus cared. That's unparalleled in the mental health field.
It's amazing the progress that this movement is making. I feel that through your work and in the generations to come, you're at a tipping point.
We really see ourselves as the organization that is going to propel change in America around mental health.
They're the leading organization on college campuses. All of our players come from college campuses. So now when you come into the National Football League, guess what? We're going to continue the conversation. We're going to help you to continue the conversation. So no better way to do that than with our partnership with Active Minds.
When Color Street chose to partner with Active Minds, we knew that they had an amazing story to tell. Having a national reach through our network of independent sales associates and customers, Active Minds has given us the language we need to help them get the conversation going in the communities where they are.
I think what Active Minds has done has been an extraordinary contribution to not only college campuses, but as a model for what we can do in civil society to make sure that we look out for each other in the same way that we hope people will look out for ourselves.
The empathy, the knowledge I gained from Active Minds is something that I will carry with me long after graduating from college.
Active Minds has just changed my life. It's something that I'm not sure I would be here without. It was my savior, it was my passion, and it's something that I will never forget.
Active Minds is saving lives. Active Minds is a change maker. Help us as we continue to change the conversation about mental health.
We're just getting started again this year, and we're going to hopefully bring some more events to campus. But in the past, we've done like poster walks. So there's been stuff about eating disorders up on campus, like posters. And as you walk through like Red Square, there's been posters through there that just detail eating disorders and sort of ways to find help with that. And we also provide resources through just like advocating the Talk Now and counseling centers here at PLU. So yeah.
Okay, great. So one of the things that I always like to help people understand is what's the difference between mental health and mental illness, because we always talk about promoting mental health and preventing mental illness. So every single one of us in this room has mental health needs, right? And those needs include acceptance and support and success and feeling safe. So we all have those mental health needs. But luckily we don't all have mental illness. So diagnoses such as major depressive disorder, bipolar disorder, eating disorders represent illnesses of the brain. Unfortunately, mental illness is an old, it's an old word. We know that all of these have to do with changes in the way the brain is working, structure of the brain. I'm actually going to show you what the brain looks like in major depression so that we can get an idea that people who have major depressive disorder are more predisposed to the despair of it's never going to get better, and people die by killing themselves. And so what we're going to talk about tonight are some statistics about suicide, and to begin the conversation and not be afraid to use the word because it's predominant in our society. Suicides have doubled since COVID because of isolation, and we don't even begin to have the data on COVID and mental health problems, let alone the emergence of mental illnesses. College-age students are in a time of brain changing, and that's when 75% of mental illnesses onset between ages 15 and 25. So college campus, college age is when different mental illness may start to emerge. So people who have mental illness also have mental health needs. So we all need to be able to look at vocabulary and get our vocabulary clear. So this talk tonight is an introduction to suicide prevention. And hopefully after tonight and the title, Talk Saves Lives, you may be actually someone who saves somebody's life. Okay, what's that doing? Why didn't that go forward? It's trying to make the mouse work. Here we go. Okay. So this is a health issue. It's not that somebody has a weak will or there's a character flaw. Okay, this is a health issue. And under President Obama in 2000 and I believe it was 14 or 15, moved suicide out of the realm and the governance of psychiatry and moved suicide under the guidance of public health. So now we're really looking at depression and mental illness as public health concerns. And it can be prevented. I do want to say that major depressive disorder is a potentially lethal illness. And unfortunately in psychiatry, we have people who die from their diseases. But we have far fewer people die as a result of psychiatric illness than, say, oncology, cancer, cardiology. But it's made a bigger deal because of the very personal nature of someone who's in such despair that the only way out is to take their own life. So we're going to talk a little bit about the scope of the problem, some of the research that we know about, how we can prevent, and we're going to end up with the conversation of how it's important to talk about this. So how we talk about suicide really matters. There's some old terminology. Used to say somebody committed suicide or they had a successful suicide. I mean, that is just a horrible phrase, right? Or somebody failed in their suicide attempt. That's old language, and it's going to take a while to get that eradicated from our vocabulary. So what we are saying now is that they died by suicide, okay? It was death from suicide. Somebody ended their life and they killed themselves. Don't fall into the trap of saying, are you thinking of hurting yourself? Hurting yourself is very different from killing yourself. People who have had thoughts of suicide, have been contemplating, oftentimes for a long time, should I just go ahead and kill myself? Hurting oneself is different. We think of that when we think of cutting, and oftentimes those symptoms relate to a lot more to anxiety than it does to suicide. So don't be afraid to use those words when you're talking with someone that you are really concerned about. I can remember one patient a long time ago when I was young in the field made the comment that she had seen several different psychiatric providers and nobody asked if she was suicidal or had thought of killing herself. So she thought she must have been so bad that nobody even brought it up, that that's why she should go ahead and do it. So people have a lot of anxiety who are having those thoughts of wanting to kill themselves. And it's a burden reliever to actually have somebody say, is it so bad you were thinking of killing yourself? And the person will respond most of the time. There are a few people that will deny it and then go ahead. I had a college roommate back in the 60s, okay, that's how old I am, you can do the math, who died from suicide. She was a nurse. She graduated in our group, and she married a guy, went to Vietnam. He came back with a really, really bad drug habit and became violent, and she ended up having to divorce him, but she was madly in love with him, but she couldn't live with him. And the song that was they played at their wedding became a popular song about 10 years later, and every time she turned the radio, she heard that song. And she was seeing a psychiatrist, and she was, staying at home in her parents' house, and she just heard it too many times on the radio, and she saw her psychiatrist, and she had it planned, and she knew that her parents were going to be gone, and she killed herself that night in the basement of her parents' house. So we all had our 50-year college reunion 3 weeks ago, and we talked about her because it's devastating. Suicide is devastating. It never goes away. Here we are 50 years later, still grieving the loss of Murph. And so if we can do something to prevent, and by bringing it out and talking about it and helping people verbalize those painful thoughts, then that's an important thing to do. So what is the scope? It's reported 800,000 around the globe, and that's reported. And there's many more because there are many countries that don't acknowledge mental illness, that it's not talked about in their culture. So this is the reported number worldwide. My guess, and especially now with COVID, my guess is that's going to be about 1.5 million to 2 million people. We do know that in America, somebody dies by suicide every 40 seconds. So when you think about on this campus, I've been here going on 8 years, and this was the first death, maybe second. Thousands of young people who've come through. So this campus is a warm community, it's a family, and does its best to try to reach out and provide resources. So we know that it's the 10th leading cause of death in the country, but as we saw in the video, the 2nd leading cause of death in college-age students. And 2018, which is the most recent data prior to COVID, there were documented 48,000 people who died from suicide. Now, how many single car accidents, how many other deaths were suicide but not reported as such? We're never going to really know. But for every suicide that someone has died by suicide, 25 others have attempted, and of that, hundreds have thought about it, and of that, many hundreds have gone to the ER. So many people go and seek help, so that the actual number of people who die by suicide compared to those who experience thoughts is quite small. So that's why if we can reach out to help people who are having those thoughts, we can prevent a death. So we know that it's very expensive. It's about $70 billion a year in potential lost wages and the effects of care. So what do we know? Why do people take their own life? Why do people do that? There's no ever one reason, but it's always a multiple, and we can start looking at what we call predictors and what we know that cause people to be vulnerable. So the large number who die do have some type of a mental illness, or maybe an overwhelming unmet mental health need. So not everybody has mental illness who dies from suicide. You can have really a lot of mental health, a lot of worry, a lot of anxiety, and you're thinking, I don't know what else to do. I have to take myself out. So not everybody has mental illness, but everyone has a lot of unmet mental health needs who die. So there's a very famous researcher, Dr. Thomas Joyner, who is one of the most beautiful people, and I know him personally as a psychologist whose dad died from suicide, a brother died from suicide, a grandfather died from suicide, uncles died from suicide. It's just all over in his family. So he became a suicidologist and devoted his life, and he's come up with the most brilliant description, and his book is called Why People Die from Suicide. And I want to take you through this diagram because it's really helpful if you're trying to, sort of categorize these vulnerabilities and precursors. So if we think about people as a whole who die from suicide, basically it's two areas. Either they perceive that they're a burden to society, to their family, to where they live, or they have what's called thwarted belongingness, just don't feel like I fit in. And you'll see this a lot in high school kids. They just don't feel like other kids. So these are the two major reasons that, you can take all of the predictors and lump them into these two categories. So we see a lot in older people who kill themselves, people who have dementing illnesses, people who feel like they are both a burden and nobody wants them around anymore. So chronic health problems are a big component, particularly in older people who die from suicide. So what we look here in this gold area is the acquired capacity for suicide. So what that means is somebody's thinking about, I have no choice, I have to kill myself. And people then pick a method and they think about it. And what Dr. Joyner said, it's very interesting. If somebody has decided they're going to kill themselves from an overdose or from hanging or from throwing themselves in front of a train, people will pick a method and keep that method, which is interesting. So individuals start thinking about it and thinking about how can I do it? And I don't want to do it and not have it work. I don't want to wake up to the shame. So people go through what's called rehearsal. And if they're thinking about a gun, they will actually get a gun and hold a gun. And they'll take an unloaded gun and maybe hold it to their head. They'll do these activities to get themselves comfortable with the notion that this is what I have to do. And so if you're talking with a friend and you ask that tough question, God, are things so bad that you're thinking that you have to kill yourself to solve the problem? You know, what's going through your mind? You know, what are you thinking of doing? Tell me what you're thinking of doing. I want to be able to help. Well, nobody can help me now. I've already made the decision. Someone may say, no, 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 no. I'm not going to leave you alone. And you can ask people. It's so important to engage them in conversation. You don't have to be embarrassed about that or think that you are, you're going to make them do it. That's an old myth. Oh, if I bring it up, then they'll do it. Well, no, not bringing it up is what oftentimes promotes that. So as people acquire this capacity, and that intersects with one of these self-concepts that I'm a burden to others or I don't belong, that's the risk area. So asking people about how long have you been thinking about it, and do you have a method? So one of the patients I saw in the clinic was a young man who was going through heroin withdrawal. And he'd successfully withdrawn from heroin, but life without heroin was horrible for him. And so I said, how long have you been thinking about killing yourself? And he looked at me and I said, I've been doing this a while. It's been going through it's been rumbling through your brain. And I'll use that word as any of those awful suicide thoughts rumbled through your brain. And he goes, yes. And I said, how are you going to do it? He said, well, I've thought a lot about it. I'm going to put myself in front of the train here in Tacoma. And I said, have you gone to the train tracks? Yeah, I know exactly which track I'm going to. And he said, I've stood there. I know when the trains are coming. I said, have you actually laid down on the track? Yes, I have. What got you off the track? Well, when I felt the vibrations, I thought, this is really real. And so he was able to talk about it. And I was glad for that. So he did not kill himself. And we were able to talk about what he could do. So I just can't stress enough to bring up this very difficult subject. So we know that 1 in 4 people have a mental health problem. Some of those go on to be a mental illness, but most do not die by suicide. When we looked at that number from 2018, 48,000 people, that's still 48,000 people too many, but there's 300 and some million people in our country. So there's a lot of resilience. There's a lot of hope. And it just takes one person to help someone feel hopeful. So we do know, though, that the people who have died from suicide have different brain chemistry, okay? And there's different, sometimes, structure. So we're going to look at this picture. This is a PET scan, positron emission tomography. And what we're looking at is a slice of the brain. If you would take your brain off at the ear and look up from underneath at the bottom, this is the view that we would see. So this is the right side of the brain, and this is the left side of the brain. These are ventricles, which are holes in your head, right, where cerebral spinal fluid circulates, and that's the nutrition to your brain. So what we're seeing in the green is that the brain structures are there. The yellow is that they are ready to receive an impulse, and red means that part of the brain is firing off. So when a person is in a scanner, they're lying calmly at rest, not thinking about anything, and you shouldn't see much red when a person is in an at-rest brain scan. So this is the frontal lobe of the brain, okay, right here in your forehead, where we're actually doing our thinking and our planning. And this is the prefrontal region, and that's where we have cause and effect reasoning. So if we think, okay, if I'm going to do this on Saturday, I need to have this ready today. Okay, cause and effect reasoning. If I do this now, this is going to be a potential outcome. This area in the brain is very important. It's called the thalamus, and it's deep inside the brain, and that's where all incoming sensory information comes. So vision, hearing, taste, touch, all go directly to the thalamus. And those impulses travel up to this area of the brain. There's nothing coming in right there because the person's in the scanner with their eyes closed. Goes to this part of the brain called the caudate nucleus, and then transfers up to the frontal lobe, and the frontal lobe decides what I'm going to do with that information. So this is a good-looking, normal brain at rest, and this part of the brain is where the emotion center is. So when we look at depression, clinical major depression, there's a little difference, isn't there? It just looks depressed. I call it the blue brain, okay? So what this is showing is that there is a deficit. So in major depression, there's a deficit in enough chemistry to run the brain. So oftentimes it's referred to as a chemical imbalance, and that's true. So people need to be in treatment, need to be on some antidepressant medications, and the antidepressants don't cure anything, but they juice up the brain, okay? Major vitamin pill to the brain, and it'll give it enough chemistry to run, so that if your brain is running okay, then you can problem solve and think and remember and plan and organize and have emotions, etc. So a person who has, get rid of that, a person whose brain is in this state, they're not going to be able to go to class, they don't have hygiene, okay, not going to be able to take care of themselves, don't want to talk, can't organize their thoughts, are really sad, okay, have lost interest in their lives, passions, maybe feeling guilty, sleep is all just really not normal sleep for them. So the good news and the bad news is, the good news is it'll get better whether you treat it or not. The bad news is how long that takes in this type of level of depression. So the average episode of serious major depression is like 9 to 24 months or so. It can go in some cases all the way up to 48 months. So what happens is a person starts on medication and maybe some therapy and starts feeling better and gets tired of taking pills, right? Or they'll say, and I remember one woman I was working with, been about 18 months since her depression started, and she goes, I just don't think this is doing any good. And I say, well, look at you. You've got good hygiene. You're back to work. You're taking care of your kids. But inside, you still feel blue because it's a serious health problem. So if you stop your medicine now, you're going to restart a new 9 to 24-month episode. It's like, oh. So I said, I don't think you want to do that. So I really try to help people understand this is an illness. Okay. Most people who have suicidal thoughts are very ambivalent. You know what I mean by the word ambivalent? It's like, I want something, but I don't want something. And so that's when we help talk about it. So from the perspective of the person, they have reached a crisis point, okay? They're desperate to escape their pain, and their thinking becomes limited. So when that intersection in Dr. Joyner's diagram hits that red area where the capacity, the acquired capacity to carry out a suicide plan along with perceived burdensomeness, okay, where that intersects, then a person doesn't think in the same way. And that's when we really have to help people. Maybe need to be hospitalized, maybe need to take a leave, but don't leave people alone. That is the critical factor. So who do we know is at risk, okay? Health problems, general health conditions, what has been the history in them and their family, and what's going on in their lives, in the environment. So we know depression, bipolar disorder, anxiety, eating disorders, all have neurobiological bases, as well as people who've had trauma. There's so much suicide in the trauma population, people who've been victims of childhood sexual abuse, physical abuse, adolescents who've had abuse and neglect. Substance use disorders are just really highly correlated in people who die from suicide, as well as psychosis and personality disorders. which stem out of trauma. So much of this is trauma-based. Also chronic health problems, cancer, untreatable or poorly treated, I should say, diabetes, some people have severe asthma, cancer, people with chronic pain, and head injuries, okay? All are highly correlated with individuals who have died from suicide. And if it's running in the family, there's a strong, strong, strong genetic component, as I mentioned with Dr. Joyner's family. And if somebody has tried once before, that's our number one warning sign. And when we say try, that's oftentimes people who are into rehearsal, okay? So maybe I'll just take 10 Benadryl and see what that's like, or I'll take 15 aspirin, and enough that people will, you go to the ER. And so you say, oh, they're just crying for help. It's like, yeah. We don't want to blame people, right? We don't want to say that, oh, it's all their problem because they're not coping well. So when people have tried and they say, well, you didn't really try hard enough. I've heard people say that. No, that's because this person's going through this rehearsal phase. And if they're blown off and nobody's really paying any attention, then that's going to shift that ambivalence, isn't it? So there's a lot of people who do rehearsal and they don't ever go to an emergency room. They'll just see what they feel like in the morning. So when you're talking with somebody that you're concerned that is having suicidal thoughts, you say, have you played around with overdosing? Have you been mixing pills and booze? Bring it up, okay? It gives the person permission then to talk. So what's going on in the environment? What kind of lethal means does a person have? Is it hanging? Is it a knife? Is it a gun? When it's those kinds of weapon type things, we can get those and get those away from a person, right? And put them in a lockbox. I know that there are a number of people who go and get X-Acto knives. People are overdosing, they're collecting medicine. So we have to take a look at what kind of lethal means a person has, and then what's going on with stress. So I did not know the young man who died recently on our campus. I know there are several people that did, and I'm hoping that if any of those listen to this talk, maybe can begin to understand some of the variables that happened. It's not any one person's fault, ever. So if we can learn from this and piece some of these pieces together from his life, we can learn to help others. So what happens is that other people may just see somebody who's sad, or they're crying, or they're withdrawing, or maybe I'm not taking care of myself now, but we don't know what's behind anybody else's front door, right? We don't know what's going on in their genetics. We don't know the level of someone's depression, their stress, okay, and their alcohol intake. So research now is looking at those very important biomarkers, those genetic indicators. Therapy is absolutely critical. Cognitive behavioral therapy is really helpful. And we have different medication interventions as well. So we want to look at protective factors, and that's one of the things that the campus has. And we're hoping that Active Minds, as it grows and grows, becomes a protective factor at PLU as a resource. And we're modeling our activities after the national days. And there's something every single month now in America related to mental health promotion. So we're really, is it a good thing to see that? Well, yes, it's good for advocacy, but it's a sad thing to think that there's something every month that is being focused on, because that is how big the need is. So we have resources here on campus, and I think, did we have a list of those that we're gonna provide, or are you gonna mention that at the end? So we all know we have the Counseling Center and Luth Telehealth. How many of you know about the Luth Telehealth? A few. Free counseling, on demand, 24/7. So if you just look up Luth Telehealth, it will get you to, and it's very easy to set it up. I would encourage everybody to set up their Luth Telehealth account And then if something's coming up and you need to talk to somebody, or you're with a friend and you go, oh my gosh, they're thinking of suicide, sit there together and call Loop Telehealth and put that person on with a counselor. It's a wonderful, wonderful resource that we have, besides the Student Health Center and the Counseling Center and the many other programs. So mental health care is important. We need to promote a culture of mental health where we can talk about it, right? And to be smart about it. So mental health needs to be a priority. And if you yourself are here and you've had some of these really awful thoughts and you don't know what to do about them, talk to somebody about it. And if even just starting yourself with the Loop Telehealth in the privacy of your room because you don't feel, you feel embarrassed, that's a great place to start. But talk about it to somebody, okay? Get some help, an evaluation. There's so many things that we can do to help folks, and it can be tailored. So we now know that we have a law. It's called parity. So the law is there, but not all insurance companies abide by the law that physical illnesses get reimbursed at a certain rate, so must mental health, all must be paid for now. And so that's been a really big, big help. So what can you do in the meantime? All the things that we know that promotes physical health, because if the health from your neck down affects your brain health, right? So you got to take care of your body. You have to get at least 6 hours of uninterrupted sleep. That is the key. 6 hours of uninterrupted sleep. What that does, it gives you 4 REM cycles so that you can heal your brain. And you need to try to get those 6 hours at roughly the same time every night, like 11 to 5, 12 to 6. If you get more, that's great. But it's really important to get 6 hours of uninterrupted sleep. So your brain has to heal from the stress of the day. Exercise is really critical, half an hour at least 3 times a week, if not more. A diet with no sugar, caffeine, fast foods. It's like a boring diet, right? But you need leafy greens, healthy smoothies, etc., and a way to manage stress. A lot of people will manage stress through meditation, through prayer, through just getting together with friends. Some people like to go out in the woods, go climb a mountain, listen to music, take a hot shower. There's many things that people have that help them manage stress, and just breathing. So I'm going to teach you all one very important way to breathe, okay? So I want you all to put your hands here on your bellies, okay? And I want you to breathe in through your nose, and you push your hands out. So you want to breathe in as deep as you can through your nose. And you feel your whole belly come out, okay? And hold that to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Blow it out like you're blowing out a balloon. And when all the air is gone, squeeze out more. Now this time, close your eyes, and another one, real deep. Push out your belly. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Push out more. One more deep breath in. Hold it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Blow it all out. Okay. Now, breathe normal. What do you sense? Do you sense a little change in your body? Maybe even a little lightheaded? If you practice that, what you're doing by this deep breathing, there is a nerve that comes from the back of your brain, okay, all around. There's an upper and a lower, and it goes all the way down through your diaphragm, and it comes out your rear end, okay? It's called the vagus nerve. And the dorsal vagus, which is in the lower part from the diaphragm down, that's the one that kicks in with anxiety. So have you, when like your mother would call your name in that certain way, and you know you're in trouble, and you get that pit in your stomach, that's that vagus nerve kicking in. And when you stretch up and you breathe like that, you push your diaphragm down, it automatically suppresses that nerve, and it will keep you from just really getting anxious. And when you do that, you engage what's called the ventral vagal, which is social engagement. You can look at people in the eyes, you can talk, you can have melody in your voice. But if you're running around in your dorsal vagal, it's really super high anxiety, okay? And it's real hard to think and process. So that deep breathing is really critical. Okay, so that's our mental health intervention for the night, right? So I want you to practice that. Okay, so we need to support people when there has been death from suicide, just like we support any other death, okay? Survivors grieve forever. Forever. We miss that person. And we keep thinking, oh, could I have said something? Did I miss something? And with Murph, we did. We didn't know as much that many years ago as we do now. We'd be much more aggressive. So now is a much better time to be able to deal with the pain of suicide because of how much we know. So the most important thing you can do, you can put between a person and their way of ending their life is time. Time. So if someone is suicidal, you say, you know what? You're going to come stay with me for the weekend. I'm going to talk about this. I'm not going to let you be alone. And stretch out that time. If somebody has done a rehearsal attempt, again, don't leave them alone, okay? And if you personally can't, then we find somebody that can. Our most difficult population is our homeless population. You know, it's so hard to find good resources for individuals who are homeless. So we want to limit access to means, if at all possible. If somebody is thinking about a train, it's kind of hard to do. So we do know that men tend to choose more aggressive, violent means, such as gunshot. Women choose to do more less aggressive, such as overdose. So if there is a gun involved, as healthcare providers, we always have to ask, where is the weapon? Who has access to the weapon? Is it locked away? Is it removed? That's a little more difficult here on campus, but you still have to ask the question. So we can look for carbon monoxide sensors in cars. We can have pharmacies do a blister pack. Means you have to push each pill out one at a time, and sometimes you can say, you know what, it's just going to take way too long to get all those pills out. Barriers are being on bridges now. So I live in Gig Harbor, and there was this huge activity. There's a big suicide prevention group in Gig Harbor, and it took 3 years, but they finally got permission from the DOT to put the barriers up on the Narrows Bridge, which it's a limiting factor, right? So somebody can't just jump off, but they have to go through a lot of climbing. It can capture that ambivalence. So what can you do? I hope, as I've said already, have the conversation. Watch for the warning signs, reaching out, seeking help. So what are the warning signs? How a person is talking, how they're behaving, and what's their mood doing. So people are actually talking. Some people will talk about, you know, I don't have any other choice. I'm going to kill myself this weekend. Some people say, oh, you're just joking. So some people will drop that clue and see how it's responded to. Or they'll say, there's no more reason for me to live, okay? I'm just a burden. I'm trapped. I've got too much emotional pain. And it's so tragic. We see in high school kids, you know, a romantic breakup is oftentimes the trigger that trips that person into feeling, I don't fit in. So we know that, you know, significant relationship breakups are really one of the warning signs. So is somebody drinking more? Are they getting stoned? Are they getting high? Not sleeping? Ugh, sleep disruption is a big physical sign. Are they starting to act reckless? Get picked up with a DUI or, speeding tickets. They're testing, okay? Folks who have active suicidal thoughts do these kinds of testing. Or they're withdrawn, they're dropping out of class, not taking care of themselves, not talking to friends, and maybe they're exploring. You can look up online successful methods for suicide. I mean, it's online. It's just mind-blowing when I learned that. It was many years ago. And ultimately, if you start seeing people give away their belongings, that's also a warning sign. So we see changes in mood, people more anxious, maybe they're talking, they're more humiliated about maybe failing a class, not getting work in on time, or you may see the other people get really rageful and irritable. So always trust your gut, trust that, okay? And you be the one that reaches out, and you're not gonna say anything wrong, okay? Not saying something is more wrong than saying, you know what, I don't know really how to ask this, but oh my gosh, I listened to this talk about suicide. Are you thinking of killing yourself? Don't say, are you thinking of hurting yourself? Use the word killing yourself. I know that sounds harsh, but that's what people are thinking about. So how to reach out? I'm going to do it privately, and just be prepared to listen. You can't fix it, but you can be the one that listens. And be concerned. Obviously, if you weren't reaching out, if you weren't concerned, you wouldn't be reaching out. Ask directly, are you thinking of ending your life or killing yourself? It's okay to use those words. And say, you know what? I'm going to help you. Let's start with Loot Telehealth right now. I'm going to get a counselor online, and I'll stay here with you while we do that. Try not to minimize it. Oh, it's not that bad. It'll be okay by the end of the semester. It's not that long till J term. We always want to, that's the human nature in all of us. We want to minimize it. It's going to be better later, okay? And don't say, oh, you've got everything in the world to live for, because they're not thinking about the future at all. They're thinking about right now. It's too bad now. So say, all right, we need to make now a little bit better. Let's go to a movie. Let's get out of here. Let's go to a movie, okay? Let's go out for a walk, whatever you want to. Let's go bowling, whatever. Actually getting people moving is really pretty important. And just don't give somebody advice, Well, you know what? Why don't you call the counseling center? They're not going to do that, right? They're just not going to do that. You're going to have to be the one to say, you know what? I'm going to take us tomorrow. I'm going to stay with you tonight. Tomorrow I'm going to walk you over to the counseling center. I'll be there with you. It's that human connection. Just be yourself, okay? You don't have to be a therapist. You don't have to say the magic anything. But your presence, your reaching out, your listening is what is the most therapeutic. So if you're thinking somebody, oh my gosh, they've just taken 250 aspirin, okay? You go right to the ER, okay? Stay with them, or you get help, you take them to get help. So here is the Suicide Prevention Lifeline and the crisis. This is great. So we had several nursing students a few years ago that became crisis text line volunteers. So if you text talk to that number, you'll get a counselor right on the spot. And it's somebody to talk to. So the texting has been really, really important. So that's a great resource. And obviously there's 911. So as we wrap up this portion here and we get to some Q&A, I want to think about a culture here where it's okay to talk about it. It's okay to intervene, okay to think about it. We can prevent this, and talk saves lives. So thank you, and we'll have some question and answer now.
There's one in the chat. So somebody asked,
Okay, I'm gonna have to tell you, I'm real hard of hearing, so I can't hear through a mask. I have to see your mouth. Okay, say that again.
Okay, when you're telling the story about the man and the train, they asked, how do I talk to someone about this? And I feel like I might be overwhelmed by the response I might get.
Oh, that's a great question. Thank you. So the question was in relationship to the story about the person I said who was going to lay on the train tracks, and the person intervening, I think I might be overwhelmed. That is a really great question. Of course, that's shocking to hear, isn't it? I mean, shocking. Just say, you know what? That is really, must be extremely scary thoughts in your head. How long's that been going on? Just try to get the person to talk, okay? And say, again, I'm not gonna leave you alone. We're gonna talk more about it. I'm not maybe the best person, but I'm gonna get some help for you. So we're gonna text on this text line right now. And of course, it is overwhelming when you have a friend and you find, oh my gosh, maybe you've known somebody for a long time and you find this stuff has been going on in their head. It is overwhelming. But don't be afraid of that. You're not going to say anything wrong, okay? You're not going to be the one that pushes somebody over the edge. You don't have that much power. I don't have that much power. But you do have human connection. So that would be how I would answer that. Is there anything else that came from the text or the chat? Okay. Did we have many people watching? How many? 8. That's good. Okay. So some questions here. Don't be afraid to ask. Yes? I need you to put your mask on.
Do you have any tips for dealing with a person who thinks it's okay to make jokes about suicide?
Oh, gosh.
Talk about it and sometimes they think it's funny.
Yeah, so the question is, are there tips for people who make fun of it? Well, other than slapping them, which is not a very effective intervention, just say, you know what, is that, what I would say is, have you known somebody that has killed themselves? Are you thinking about it yourself? Some people will make light of really tragic things because they don't know how to deal with it. So I would just always say, you know, I don't understand making fun of this. Go with your gut, like, you know, why would you say that? Say that. If that's what you feel, say that. It's when we hesitate trying to come up with the right words, you know, that everybody thinks I've got to say it just right. You know, I'm not a therapist, but you would just be yourself. That is the most important. Thank you for that question. It's great. Yeah.
I just wanted to ask, like, you were mentioning how, like, situations where the person may be responsive to you asking, are you okay, and stuff like that. But what would you do in a situation where they're not responsive and they're, you know, shutting down and just pushing everyone away?
So the question is, what do you do if somebody's not responsive, they're shutting down and pushing everybody away, which is really common, particularly in young people. That's a huge warning sign. So you would say, you know what, I'm really pretty concerned about you, and I'm going to see if I can get some help. No, I don't want you to do that, you won't be my friend anymore. Then say, okay, and I'm gonna stay with you, and I would, again, do the text line. And even if you just want to go out in the hall, right, you make sure that person's okay right now, step outside, use the text line and say, hey, here's the situation I've got, what should I do? I know that the RAs have had some training, and I'm sorry I don't know the answer about kind of after hours emergency. Do any of you know is there a policy if someone is suicidal after hours? I mean, after hours, I mean, like we have hours to commit suicide, right? You want to come up to the mic so that'll get recorded? Thanks, Sammy. Yeah. Yes.
I'm pretty sure there's a RA on duty also.
I know that there are RAs on duty, and they have these resources, right, that they can reach out for. Yeah. So is there anything in the talk that surprised you, that you learned that you didn't know before? The teacher in me wants to engage my classroom here.
It was just surprising, or just, I guess you wouldn't really think about it at first, just the language you use when talking to people. Like, at first thought you wouldn't say, like, or you wouldn't think of just facing it head on and just talking to them about it.
Yeah.
That was
Yeah, good. Yeah, so his comment was, you don't think about just using the words, killing yourself or ending your life. Yeah. And that's the humanness in us, right? We want to make it better and soften things down a little bit, but this is a desperate situation. So we use the words. Anything else? Okay. Do we want to wrap up with anything about Active Minds or anything? And we will get people out in the hour that we had asked you to commit tonight, so we appreciate that.
Yeah, so hi, I'm Sammy, I'm the Vice President. Obviously there's Maria, our President, and Marie, our Treasurer. I'm also kind of the Secretary. As you can tell, we're very low on members right now. So we wanted to go over again your resources. PLU is the counseling center. You can do walk-in appointments. You can also schedule appointments. That can be short-term, long-term, whatever you think is best for you. There's the crisis line I mentioned, and then telehealth. If you would like to stay after, I'm happy to try to help you set up that account right now. We'll also probably do a tabling event later to help people set up those accounts. There's also the National Suicide Hotline and the Crisis Text Line. There's also the Trevor Project, which is for LGBTQ+ youth, so that's helpful if your issues are related to that. And then I also just wanted to share a little bit more about our club. Our Instagram is activeminds_PLU. We will share resources there, also about meetings. We also have a sign-up sheet on the piano for you to put your name and email if you would like to join the club or just get more information. And once again, I'm happy to stay after and help you set up that account.
Okay. Thank you, everyone. And yeah, we can hang around for a little bit, but he has one-to-one questions, so. Okay. Right. Yeah, thank you.